Dear colleagues, nice to meet you again for this interesting Meet the Expert session sponsored by ESTOR and Spectral. And the theme of this section is Endotoxemia and PMX therapy, a picture from the real clinical practice. And the reason why we describe clinical practice is because Salvatore Cutuli from the University of Rome, Policlinico Gemelli, and the Department of Intensive Care and Anesthesiology, I think will have the possibility to present us some data relative to the scientific registry called UFAS-2 on Polymyxin B hemoperfusion. So with no further ado, thank you for joining us, Salvatore. And can you start telling us, maybe you have some slides to share with us, what about the use of Polymyxin B hemoperfusion in septic shock today?
Good afternoon, everybody, and thanks for the invitation to this conference, and thanks, Professor Ronco, for the nice introduction. I prepared some slides just to tell you something about Polymyxin B hemoperfusion in clinical practice. So the clinical scenario that we are taking care of is septic shock. And as we learned from a recent definition, septic shock is caused by a dysregulated inflammatory response to an infection, which may be caused by bacteria, virus, or other microbiological species. And if we look at the different mediators involved in septic shock, we may have molecules coming from pathogens and molecules coming from the organism, and both may activate the inflammatory response and may be associated with inflammatory dysfunction. In this context, endotoxin, which is a molecule that is contained in the outer part of the gram-negative membrane, outer part of the membrane of gram-negative bacteria, is an important mediator. It is a pathogen-associated mediator, and as you can see in this picture, it activates many different inflammatory pathways, and the dysregulation of these pathways may be associated with sepsis and multi-organ dysfunction. In this context, Polymyxin B hemoperfusion may be something that really matters because it may have a role in terms of endotoxin removal. And endotoxin endotoxin removal by Polymyxin B hemoperfusion is allowed because of a specific characteristics of this device. Basically, it is composite of Polymyxin B, which is an antibiotic with a very high affinity for endotoxin. And in this way, it can have a contact with the blood, and then it may remove endotoxin from the blood, and then it may clear the blood. So in this context, it may have an important role to immune modulate the inflammatory system of the patient, because it can reduce the activation of the system itself, so it may limit the dysfunction. And what we observed in clinical practice was that Polymyxin B hemoperfusion was associated with an improvement in organ dysfunction. Here we have the results of the EOFA study. It was a randomized controlled trial which was done in Italy. And it was published 11 years ago. And as you can see, there was an improvement in the SOFA score. Specifically, the improvement, we had an improvement in the cardiovascular SOFA score and in the renal SOFA score. And also, it was associated with an improvement of cardiac function. In this case, these data are not from the EOFAS-2, but it was another physiological study. Which helped us to understand a bit more about the role of endotoxin in septic shock and why it is so important to remove endotoxin from the blood. And here I prepared an overview of papers that investigated the improvement in mortality rate associated with polymyxin B hemoperfusion. And as you can see, it is not it's not something really new. I mean, we started to work with polymyxin B hemoperfusion in 1998 at least. And we are still discussing about it. We are still looking at the evidence about it. And the last evidence was from the EUPHRATES study, which was an important randomized control trial, which was done in North America. And again, in a post-hoc analysis of this trial, there was a reduction of mortality in patients with a certain level of endotoxin activity, which was comparable to the capability of the device to remove the endotoxin. So here you can see the reason why endotoxin really matters and where is the damage associated with an endotoxin release, which is beyond the septic shock itself. It is something that really interests all the systems of our organism. And the endotoxin is really important because it can be measured in the blood, and this is important because it allows us to have a biomarker, which is important to identify a specific population of patients which may benefit from endotoxin removal. And here we have a study which was done by John Marshall, and what they observed was that an increased level of endotoxin was associated with an increased mortality, both at the hospital or at the ICU. So that's why probably it is so important to measure endotoxin, to identify a specific population of patients, and then to start endotoxin removal. We have different devices which that are able to remove endotoxin from the blood. And as you can see here, polymyxin B hemoperfusion is the device which has the highest absorption capacity. So it is very and this is something really important because it can reduce significantly the level of endotoxin in the blood. So it is able to do an efficient immune modulation. Beyond the randomized trial, we started a registry, which is the EUPHAS-2 registry. And this registry has the aim to collect evidence from the real use of polymyxin B hemoperfusion in clinical practice, which is important to understand if there may be some population of patients with specific characteristics that may benefit from this therapy beyond the inclusion criteria of randomized controlled trial. So it was the aim of this study. And we had a retrospective part of the study, a retrospective phase that was concluded, and the data were published a couple of years ago. And the prospective phase of the trial, which is the prospective one, it is still ongoing. And here you have the results of the retrospective phase of the polymyxin B hemoperfusion in clinical practice. And what we observed was basically an improvement of organ dysfunction in patients who received polymyxin B hemoperfusion. And also it was associated with an improvement in hemodynamics, with a reduction in the requirement of noradrenaline and vasopressors. And also it was associated with a significant reduction in lactates. Unfortunately, it is a registry, so we don't have a control group. And for this reason, this is something that can be used only to generate hypotheses that may be tested in future trials. What we observed in this study was that mortality rate was different among different patient populations. Specifically, we had a very low mortality rate in patients who had a cardiovascular response, which was measured by the SOFA score, the cardiovascular part of the SOFA score. And also there was an important reduction in mortality rate in patients who had an abdominal sepsis and were treated within the first 24 hours of ICU admission. And here you can see the Kaplan-Meier's of regarding polymyxin B hemoperfusion in patients who had a cardiovascular response and in patients who had not a cardiovascular response. And you can see that the difference is impressive. So maybe we were able to at least identify a specific population of patients. In the EOFA study, in the retrospective phase, we didn't have the endotoxin activity for all the patients enrolled. That's the reason why we asked to the centers who were part of the second phase to use the endotoxin activity and to give us the data just to understand if there was a relationship between endotoxin level and organ dysfunction. And here we have the results of 29 patients with endotoxin activity measured before the treatment. So we have a baseline level and over 120 hours after the treatment. And here you can see the trend of endotoxin. There was not a significant reduction of endotoxin activity, but we are talking about only 29 patients. So even if statistics didn't help us to show a trend, at least we have a visual impact. And then we have also the reduction in terms of the improvement of organ dysfunction, which were measured by the SOFA score, the lung injury, and the rifle score. So we had an improvement in SOFA score, so an improvement in basically in organ function, and specifically an improvement in the lung function, the function of the lung, and the function of the cardiovascular and of the kidney. Moreover, what we observed was an improvement of hemodynamics, which was something that we in some way expected. That was demonstrated by an increase in mean arterial pressure, in a reduction of vasopressor dependency, and a reduction in lactates. Moreover, we collected some data about COVID-19 patients. Specifically, we looked at the level of endotoxin in a specific population of patients, in 12 patients who were admitted to the ICU for COVID-19. And what we observed was that there was a relationship between endotoxin activity and SOFA score. So there was a correlation which was significant, which helped us to understand a bit more the role of endotoxin in and to generate organ dysfunction. Of course, the trial was not something that helped us to make inference about the cause of organ dysfunction, but a relationship. But we observed a relationship, which is something. So according to these results, we concluded that there may be a role of endotoxin removal by polymyxin B hemoperfusion in clinical practice. Dr. De Rosa and Professor Rombo suggested an algorithm, basically, to place polymyxin B hemoperfusion in daily practice. So specifically, it should be viewed as a complementary therapy, which should be used only when the resuscitative therapy is not effective. So only after we improved organ function as much as we can, and the patient is not responding. So probably it should be the best role for this therapy in clinical practice. And there is maybe also a role of polymyxin B hemoperfusion in patients with COVID-19. I showed us some data, some preliminary data. And here we have an overview of the use of polymyxin B hemoperfusion worldwide. Specifically, it was approved in Europe, in Russia, and then in Japan, in Asia, and in the US. Of course, it was used, it is suggested as a compassionate use, so it's only for patients who are not responding to the standard therapy. And it is important, specifically in this disease, not just to treat the coronavirus. So it's not useful to remove the virus. We didn't test it, but it is important because we observed an important increase in infections, specifically in bacteremia in this patient's population. And the reason why patients with COVID-19 may have an increased risk to develop an infection is due to the therapy that we use. For example, tocilizumab, steroids, But also what we know is that there is a kind of immune suppression induced by the COVID-19, which may justify the increase of the risk of infection in this patient population. And for this reason, the polymyxin B may play a role. What we also know is that this device is not only useful to remove endotoxin, but it has a direct immune modulating function. And here we have a randomized control trial, which was published a couple of years ago. And as you can see, there was an improvement in immune suppression, which was measured by an increase in HLA-DR receptor. So that's why probably it could be worth to use polymyxin B hemoperfusion in this patient population.
Okay, very good. You answered most of the question that I had. Time is running, so I have to close this session. I thank you very much for the exhaustive presentation, and hopefully the audience can also follow the symposium on the role of polymyxin B in endotoxic shock and COVID-19. So with this, thank you very much for joining this Meet the Expert session, and let's move on with the scientific sessions.